So I'll be talking about high and low pressure headache this evening, but what I thought I'd do is just outline what we'll cover. So I thought we'd do a little bit of an approach to headache, because low pressure, high pressure headache is sort of quite a specific topic. Cover a little bit of anatomy, because that'll be important in understanding the two different types of headache, and then we'll go through low pressure headache first, because that's quite a sort of concise area, and then high pressure, we'll do a bit of a tour of high pressure headache, because there's quite a few different potential causes. So in terms of approach to headache, whether you're seeing your GP or neurologist, there will always be an assessment that's done. So we'll take a bit of a history, we'll have a chat to you about your headache, get some information about whether it's been there for a long time or a short time, some family history, which is important for things like migraine. We'll do an examination, and then potentially, depending on what we find, we'll order some investigations, and that's usually imaging with an MRI scan of the brain. And ultimately what we're trying to do is divide people into different types of categories, and the two main categories that we're dividing headache into are primary headache and secondary headache. So when we think about primary headache, we're thinking about headache that doesn't have another sort of medical cause for it, so migraine and tension type headache. Secondary headaches have another sort of medical cause for them, and although primary headaches can be very, very debilitating and affect quality of life, they're usually not dangerous, whereas secondary headaches can be very serious, and the management often differs quite a lot. In order to understand high pressure and low pressure, we need to have a little bit of an understanding of the anatomy. So we've got a head here, and we've got skin and then skull, and our skull is quite a tight box that doesn't have any give. Within the skull we've got the brain, and then the spinal cord comes out the bottom. The brain is covered by a very sort of dense fibrous sac, which is the meninges, and then within that sac is fluid, so our cerebrospinal fluid, which is a clear colourless fluid. Our spinal fluid is made in sort of almost the centre of the brain, in an area called the ventricles, by these little areas called choroid plexus. We have about 150 mils of CSF floating around our brain and spinal cord, but these choroid plexus in the very centre of the brain make about half a litre a day, so quite a bit. So we also have an absorption system, which involves these little granulations at the top. CSF's pretty important because our brain weighs about 1 kilogram, and if we take the brain out and turn it upside down, there's lots and lots of important structures. So at the bottom of the brain are vessels and nerves, and if we don't have that fluid and don't have the brain sitting on that fluid, all of those structures could be compressed. The brain itself doesn't feel any pain, but these structures, so the meninges, that covering of the brain, the nerves and the vessels are very sensitive. So low pressure headache occurs when there isn't enough of the CSF, there isn't enough buoyancy to keep the brain floating. And that's usually because the fluid's being lost faster than it can be replaced. In terms of symptoms, the classic thing that we see is an orthostatic headache. So that means a headache that's much worse when you're sitting or standing up as opposed to laying down. Because we've got all of those sensitive structures at the bottom of the brain, including nerves that go out to the eye and to the ear, people can get double vision, they can get dizziness, tinnitus, ringing in their ears, and in very, very severe situations can have confusion and reduced conscious state and even a coma. In terms of investigations, we often do some imaging studies to help with the diagnosis. So I've got 2 MRI scans here, sort of patient being cut through the middle, and we're having a look at the brain side on. The first image is before any treatment was instituted. The second image is with some treatment. And what we can see comparing the two is the first thing is this space, which is the ventricle where our fluid's being made, is quite small if you compare the two sides. The second thing that we've got is this area of the brain, which is the brainstem, and the cerebellum, which is the sort of coordination centre of the brain, all look a bit squashed. On the second image, we can see that there's lots of space, and that space is by fluid that's allowing everything to float and be separated. The other thing is that we've got a line through here, and we can see that things are falling below that line on this set of images. The other thing that we can see is we can give an injection of a contrast called gadolinium, and that gives us information about whether a structure in the brain is inflamed or irritable. Normally, the meninges, so the surrounding part of the brain, doesn't light up and isn't white like this, but we can see that it's quite irritable from the low level of fluid. In terms of causes, there's a number of different things that can lead to a low pressure headache. Trauma to the skull is one of the potential causes. So we can see down the bottom here there's a little fracture through the bone. Fracture through the bone also tears the sac that's keeping the fluid in place. And people can get that clear spinal fluid coming out their ear or out their nose. Other potential causes, one that we come across occasionally is an iatrogenic cause, which means it's related to medical treatment. So sometimes in order to sort of diagnose particular neurological conditions, we want a sample of the spinal fluid, and we do that by popping a needle in between the spinous processes in the back. That's obviously creating a hole, and there's the potential that that hole doesn't seal up and fluid can leak out. We use quite a small needle. It's a pretty safe needle. It's not very common to get that type of problem. The other situation is an epidural. So a lot of people have them for pain management during labour. The idea of an epidural is they come very, very close to the dura and the spinal fluid, but don't cross that area. Anaesthetists are very, very good at doing that, and they do it by feel, but occasionally they go a little bit too far and puncture the dura. They have a much larger bore needle, so it's a bigger hole, and people often end up with a pretty nasty headache after that. The other group of people, which is less common again, is this group of people who have a spontaneous leak, and their type of headache can be very, very sudden in onset. It can also be gradual in onset, but it still has that orthostatic component to it. Lots of different theories about what can cause the headache. Sometimes there's been some thought that it can be a small little disc in the spine coming out and damaging the dura. One interesting thing is about 2/3 of people who have this particular type of problem have, I guess, abnormal connective tissue. So connective tissue is the tissue that holds everything together. So it's the stuff that's in between skin and muscle and bone. And some people have hypermobile joints, so those people who can bring their thumb back to their wrist. That's what we sort of mean when we say that their connective tissue is a little bit abnormal. So about 2/3 of people make up that group, so potentially a bit more prone to having those sorts of tears. Management in the first instance, particularly for sort of things like after a lumbar puncture, is conservative with bed rest and fluids. There's lots of different sort of things that people recommend in terms of caffeine and that type of thing, but the evidence base for that isn't particularly good. A blood patch is something that's used pretty often, so taking a sample of blood and injecting it into the spine where the tear is to seal it up, and then sometimes we need to get the surgeons to surgically go in and repair the tear. So moving on to high pressure headache. So we know that we've got our box, which is the skull, and in the box we've got fluid and we've got brain. So with a high pressure headache, we've either got too much spinal fluid or something, either the brain or something in the brain taking up too much space. The symptoms are pretty similar to low pressure headache. The headache itself, classically is described as an early morning headache. Doesn't have the same sort of postural, sort of orthostatic issue. People can get double vision and the sort of tinnitus and hearing change. Nausea and vomiting is more common. There's a few other sort of vision things that can happen in terms of blurred vision and pupil changes. What's interesting about high pressure headaches is we can, when examining someone, we kind of have a marker that we can look for on the exam to help us work out whether someone has high pressure or not. So on this MRI scan, the bright white is actually the clear spinal fluid, and we can see that we've got the eyes at the front and the nerve that goes out to the eyes. We can see that the spinal fluid actually goes all the way along the path of that eye nerve. So what we can do is we can have a look through the pupil with a little device called an ophthalmoscope to the back of the eye where the nerve enters the back of the eye. And what we've got here is a nice, normal, happy, healthy optic disc, which has got this very, very sharp border and vessels going through it. And then what we can see as we go along is a more swollen disc. So a swollen disc tells us that the pressure inside the brain is higher than we are expecting. In terms of causes for a high pressure headache, we can have too much fluid, which we call hydrocephalus. So I've got two CT scans here. This one here is a nice normal CT scan. We've got our ventricles and our little choroplexes, which are making our spinal fluid. And then the image on the other side, we can see that black area, which is our clear fluid. There's just too much and the brain's getting squashed. So this situation is usually solved by the surgeons popping in a little drain into the ventricle, which either drains into the abdomen or sometimes into the lining of the lung to get rid of that extra fluid. The problem with the extra fluid is either due to a blockage from the fluid draining into around the spinal cord, which can happen after an infection or can be a congenital thing that you're born with, or alternatively, if someone has an infection such as meningitis or a bleed into the brain, that can affect the reabsorption of the fluid. So fluid's being made normally, but the brain just can't take up that fluid. Other situations where the spinal fluid pressure is too high, one example would be a blood clot in a vein. So if we think about arteries, take nice oxygenated blood from the heart and deliver it to the brain, the veins drain away that fluid. They also help with helping absorb and get rid of this spinal fluid. So like someone can get a deep vein thrombosis in their leg, they can also get a clot in the veins of the brain. More common in women who are postpartum or on hormonal contraception. Also more common in people who have an active malignancy, so a cancer somewhere can make the blood sticky and make it more likely to clot. On this CT scan, when we see a fresh blood clot, it looks bright white, so we can see the arrows are pointing to a blood clot which is in the area of a vein in the brain. The other situation where we get high pressure but we don't have sort of too much fluid is this funny condition called idiopathic intracranial hypertension. So usually occurs in younger women, usually more prominent in women who are overweight. They present with headache, often have visual changes which are due to the high pressure, and can sometimes get some sort of funny pulsatile ringing in their ears. Really important condition because if left untreated can cause permanent vision changes. Interestingly, I don't think anyone really understands the mechanism for how we get to this particular group of people having high pressure, but we know that reducing weight can help with management. We've got medications we can use, and sometimes, like in the previous patient, shunts are put in to help reduce the pressure. So then we come to things that happen in the brain or outside the brain that take up space. So on the previous scan that we were looking at, something bright on a CT is a fresh blood clot. So in this situation, we've got two lots of bright areas on the scan, and both of these are, the first one's a bleed into the brain, so a little blood vessel breaking. The second one is a bleed in a blood vessel between that fibrous sac, the meninges and the skull. So in this situation, the brain itself's getting squashed with blood inside, and then there's blood outside, which is also squashing that area of brain, putting traction on the meninges, nerves, which are all painful. Other things that can take up space is the brain itself. So this set of images is from quite a young patient in his 30s who has had a blood clot in a vessel. So he's had a stroke, which we can see this area of brain has died and is no longer alive. And when brain dies, it swells. So the brain itself is actually taking up more space. In this situation, they've taken off part of the skull to help accommodate that swelling. He's probably going to have a pretty average headache, not only because he's got high pressure, but because they've also taken off a large amount of his skull. But there's also a lot of other symptoms that this patient would have presented with, including weakness down the right side of his body. Other things that can take up space and result in high pressure headache. So this scan is an MRI scan of a brain, which demonstrates a brain tumour called a GBM. And then on the other side, we've got an area of swollen brain, which is due to an infection called herpes simplex virus. And then the last thing that I was just going to mention, more because it was topical than anything else, is the concept of acute mountain sickness potentially representing a high pressure headache. So the first documented reports of mountain sickness was by a Chinese official in about, I think it was like 30 BC, who had trouble crossing, I think it's the Kilik Pass, which is in Afghanistan. He had headache and vomiting, and gave names such as the Great Mountain, the Great Headache Mountain, or the Little Headache Mountain. So the acute mountain sickness occurs at least 2,500 metres. You get headache along with a number of other symptoms. Generally it's pretty benign, and if you have supplemental oxygen or stay at that level or go down, things get better. But as shown here, if you're at very extreme levels for a long period of time, potentially without supplemental oxygen, things can progress. The vessels in the brain can become quite leaky, and then you get a build-up of pressure and get a high pressure headache. In severe situations, you can not only get the bad headache, but you can also get hallucinations. You can become very unsteady, which is obviously not ideal in the situation of climbing Everest.